In this episode, Kate Woods interviews Lee Scheinbart. They share insights for physicians aspiring to leadership roles, emphasizing intentional career planning, clinical experience, and leadership development. Here's what we discuss: how to become a chief medical officer, what are the skills required to be a chief medical officer, guidance for physicians aspiring to become leaders, key training areas, common financial pitfalls for physician leaders, collaborating with non-clinical peers, what are physician programs, the qualities of a non-clinician with a clinician, the complexities of the healthcare system, the Fire Chief podcast, dealing with stress as a CMO. Again, our guest is Lee Scheinbart. He's the Chief Health Affairs Officer at Burrell College of Osteopathic Medicine. Let's get into it.
Hi, Lee. How are you? Thanks for joining DarshanTalks today.
Well, thank you for having me. It's a pleasure.
What's your advice to people who want to actively become a chief medical officer or take physician leadership further? I know you've started a podcast for CMOs specifically, and you've created training and learning around this exact topic.
I would advise younger physician leaders or aspiring physician leaders to become intentional. And by that, I mean, make a decision by which you see another arc in the greater trajectory of your career. It is a smarter way to go about the whole thing.
Is there ever a good time to start that intentionality? Is it the year after you become a doctor? Is it 5 years in?
The sweet spot is concentrate on becoming a competent clinician and finishing both your undergraduate medical education and your graduate medical education. So earn your degree and then go off into your training program and earn your board certification. I think that those are bare minimum requirements. And then I think you should spend about 5 to 10 years in a clinical space, preferably just one, not bouncing through a variety of environments. That is enough to give you credibility, and you have the right age, even if you're a non-traditional student and you started much later than those who come right out of their undergraduate college experience. And then you can intentionally build your career from that point.
What do you think are some of the hit the ground running kind of skill sets people should have at that point?
So the first place to start is learning what leadership means as opposed to being a professional. And leaders bring calm into chaos. That's not to say an emergency room doctor doesn't do that when all heck is breaking loose, or somebody is having an arrest in the intensive care unit. But they're trained like a first responder. That's a very different circumstance. Our margins are falling. People are leaving us. We don't know what's coming down the pike. How do we approach that? We need to calm people down and begin to step through that. So first step, learning what is leadership.
How would you counsel a physician just entering into the leadership sphere, like an intentional leadership sphere, to kind of make a distinction between authoritarianism based on habit of telling, different key team members what to do and how to behave, and an authoritative presence as a leader, and collaborating across a broad spectrum of talents?
A great place to start is to look in the mirror and ask yourself, do I want to be a leader? And am I running towards something or am I running away from something? And if the answer is I'm running towards leadership, and then the second question is, do I know anything about it? And if the answer is no, they say, well, who will teach me about it? And probably the easiest place to start, if those questions are answered in the affirmative, is get a coach, get a mentor, get someone who has done this, find out what they have been through. We are trained through an apprentice model, even from our very first year in medical school. How to use a stethoscope is an apprentice craftsman trade experience. You have to watch, you have to learn, you have to see it, you have to do it. Why not do the same with leadership? So you have a young physician who becomes serious and intentional and wants to move into leadership. Find coaches and mentors to bring information, guidance, experience, perspective, and then map out what those critical, intentional steps might be.
And are there areas of education or training to that point that you think all medical leaders should think about? You trained for so many years on the clinical side. I know you wrote the chief medical officer's financial primer. Something, keyed you in and triggered you to say, this is a needed treatise. What was that?
Generically, not all physicians are poised to become the kind of leader that we're talking about. So let's recognize that most physicians have some intrinsic motivation to serve, and they want to be part of that human experience, and they will tend to stay in that swim lane their whole life. So that's item number one. Item number two, that's exactly why I wrote the book, because at some point there are folks who begin to say, not only am I interested in the finances, and they've gotten their savvy over time. They've had a little bit of the real world. They begin to, by osmosis, understand the finances of healthcare. But then there are others who have a gap in that knowledge and want to be a leader. And that is exactly the audience that we wrote the book for.
What kind of financial pitfall do you think is the most common that a physician leader initially falls into?
The physicians don't know their own value as a physician executive. In twofold, they don't know the value equation or the value add or the value. So all of these C-suite terms, they don't
Yeah.
even know what I'm saying, right? I have to
Yeah.
translate this. You have value in the clinic. You produce revenue from the work that you do. So there is a sense of value related to the work product that you create. And the benefit is the result of the patient, the outcome, the health, the wellness, et cetera. But beyond that piece, the clinical mind that enters into administrative roles can bring a tremendous amount of value to an organization that works on a very thin margin. Why are we using all of these different surgical devices or uh, procedural trays or preference for this or preference for that? The outcome is the same. The scalpel blade is just as sharp. Why are we spending 10 cents when we could be spending 5 cents? And the clinician is much better equipped to look for waste and inefficiency and poor use of our resources and still have the right outcome. So if the clinical executive knows that, then they have value. The salary, the time, the energy is tremendously worth it to the organization to have a physician executive being able to bridge those two arenas.
Where do you think that physicians can partner and collaborate with non-clinical peers in the healthcare system to kind of strengthen their confidence in those areas that they maybe are not totally aware that they're bringing the value that exists, right?
So a really effective, seasoned physician executive who goes through the requisites of being coached, mentored, taking classes, and learning about healthcare as a concept beyond the bedside, the entire dynamic of it, then they are prepared to create value, ask for resources, do their own budgeting, or bring on their financial support team to help do that with them, and begin to direct what they're looking for, and therefore raise their own value to the organization. So I think you have to start with a curious mind on the non-clinical side, and suspend your belief that the physician isn't all-knowing, that the physician isn't someone you have to be deferential to, and find equal footing. In fact, we have a program at the AAPL that is going to focus on mastering the dyad relationship, because it does not come natural, and it is important to begin to meet people where they're at, so that the non-clinician, the clinician, they begin to understand, where do we find this magic value that's important to all of us. So I think it has to be collaborative.
Yeah, I love that you're thinking about that and creating programs around it. Is there anything you can tell me a little bit more about that program and what the focus is?
Very talented physician executive coaching programs do this. And so, Kate,
Yeah.
we're going to put you through, say, a Hogan assessment. Lee, we're going to put you through a Hogan assessment or any other measures
Yeah.
of personality traits. And we're going to see where you fit, where you don't fit, lean into each other's strengths and weaknesses, and work on your own triggers and your derailers. That is part and embedded. And it's not specific to our course. Anybody can do that.
Oftentimes, the patient experience of the healthcare system is I go to see my doctor, there's a nurse there, maybe a medical assistant in the office, and then, of course, the hospital system. There's a whole beehive. What qualities do you think make for an effective colleague of a non-clinician with a clinician?
Both sides have to agree to this very early.
Yeah.
Suspend belief.
Yeah.
Um, we all carry stories in our head. If you introduce yourself, hi, I'm Kate and I'm a lawyer, I immediately, because you can't help yourself, conjure up. But I have to accept you as Kate, not as a lawyer. If you're my practice manager, I have to accept you as Kate, not my practice manager, and vice versa. You see this doctor, she walks in, white coat, stethoscope, scalpel in hand. Suspend all your narratives about that individual and say, well, he or she went to high school like I did, or homeschooled, or what have
Yeah.
you. And his name is Lee. And let's get to know each other. Let's understand how we work together. And I think it is more about the style in which we engage other people and meet them where they're at. And if you cannot do that, then you'll never reach the level of your question. What makes for a good partner? How are we going to
Yeah.
accomplish things? Because if one or the other holds some resistance and says, well, you're on the dark side, or you just want my money, or you're just overhead, you're just a pain in my butt,
Yeah.
you're not going to get anywhere.
Nice way of breaking down any type of relationship to its simplest form. Because, yeah, we're all working, it's a business, but at the end of the day, it's how are people working together?
The starting point is the conversation to redesign that interior structure. Why? Because there's two things that stay with physicians their entire career. One, who is on call, and number two, how do you split up all the money? And it's the splitting up of the money that has created the structural difficulty.
For sure, right? It's the follow the money. And the money always goes somewhere. And every change we make, the money doesn't disappear. It just, to your point, it goes to a different pot. I'd love to talk a little bit about your Fire Chief podcast. And first of all, it's such a great name. And let's share with the audience and our listeners and
Yeah.
like the intent and goal of the podcast.
A buddy of mine who is a physician executive in Texas, he and I began to collaborate on the idea of a book that would equip chief medical officers around the United States to manage their next disaster, which I knew was coming. I began to realize when you learn to become a physician executive, and ultimately, if you become a chief medical officer, you are not taught any of this. I don't care which master's program you have succeeded in earning, you are not taught disaster management unless you are an emergency medicine or emergency prep doctor and you've taken additional training. And we began to craft how we were going to do it. And we realized the easiest way to do it was to interview people. And then we thought, well, why do we need to write the book? Let's just interview people and put it out there. So we're just now getting into some of those very, very interesting stories about what it's like to be a chief medical officer. So even if you have not lived through a very serious crisis and have been placed in front of the press at a press conference, there are still some incredible things that happen to you in that role that no teaching program will offer you.
There must be stress levels that CMOs and other medical leaders deal with. I would imagine sometimes there's PTSD when you're in these crisis situations. Do you have any advice for proactive and reactive self-care and things that medical leaders need to take into consideration for their own selves in order to be effective leaders?
If you have to put a lot of energy into managing your stress, don't be a CMO, because you'll spend more time managing that than you will being an effective leader.
Yeah.
For those that do find themselves in situations that are above and beyond, like COVID-19 or a fire or a mass casualty episode, what I would say, Kate, is outside of the military, we are the only profession that are so rigorously trained to experience sleeplessness and to be ready at a moment's notice. So I think what happens is we go into our trained mode, and because you're trained in your 20s, it's stuck with you. If my phone goes off at 3:30 in the morning, I'm wide awake, ready to answer a mountain of questions, whether that was COVID or my own patient who was very, very sick. But I think we are trained to be these people, and that's what gets us through it. And I don't think that's a specific proscription or prescription, but I hope that gives you a frame how I would approach it, and I would advise anybody else to approach it.
Yeah, no, I loved listening to how you thought about it and where you're, I mean, I can't think of a more interesting topic to end our conversation today on. Really appreciated your time, Lee, and getting to know you a little bit today. So thank you so much.
You're welcome. It was great, and I appreciate you having me on the show.
Call, click, or email